Um, it is indeed very happy to welcome you all to the webinar series. It is a gracious gesture of East West Pharma for the benefit of postgraduates in all over India. And the program is planned in such a way that it covers most of the major topics in dermatology, venereology, and leprology. We have Dr. Vinithavarghese, who is the head of the Department of the Institute of Medical Sciences, Kochi. And she is a very good teacher and very good orator. And she is talking about Donovanosis. Donovanosis is not a very common sexually transmitted infection, but nowadays there is a little bit of increase in the occurrence of this Donovanosis and other minor sexually transmitted infection. However, it is important to know Donovanosis from the point of view of examination as well as when you start practicing. Some of the cases may have a differential diagnosis of Donovanosis. Anyway, we should eagerly learn about Donovanosis, and I invite Dr. Vinithavarghese to deliver the lecture. Thank you. Over to you, Dr. Vinny.
Thank you, sir, for the nice words. I think it's a great initiative. This All India PG webinar is a great initiative by Crichton, sir. It's a very useful program for PGs, and as sir said, at the end of this series of webinars, they will have adequate knowledge of what a PG should know at the end of their course. And thank you, sir, for the nice words, and thank you for having me here. It's a great honor to be a part of this meeting, in fact. So I will go straight into my topic of Donovanosis. Donovanosis, as sir said, it's not a very common disease that we often encounter, but Donovanosis often comes in the differential diagnosis of many important conditions that we often encounter in our clinical practice. Donovanosis is a chronic, slowly progressive, mildly contagious disease of venereal origin. It is characterized by granulomatous ulceration of the genitalia and the neighboring sites with little or no tendency to spontaneous healing. That's a very important salient feature of this disease. And it is an infection caused by Klebsiella granulomatis. And the earlier name of this organism was Calamantobacter granulomatis or Donovania granulomatis, and is a disease which is easily forgotten and poorly pursued. It has been known by various synonyms. You can see it in the textbooks. It is called as a contagious granuloma, sclerosing granuloma, phagdenic disease of the genitals, venereal granuloma, fifth venereal disease. All these are the synonyms. And before going into the disease as such, it is very important to know about the history of Donovanosis. And like many of the other STDs, Donovanosis was first recognized in Chennai. It's a very important thing. Often people forget that important point. It is first recognized in Chennai by actually MacLeod. MacLeod was a person in 1882 who actually first described the condition under the name of serpiginous ulcer. However, he was not able to identify the causative agent or give any further information about the disease. In 1905, Major Charles Donovan, who was working in India during that time in Chennai, he discovered the causative agent of the organism, causative organism in exudates from oral lesion. And in Maramal and Santora in 1950 coined the term Donovanosis. And another important contribution to this disease was given by Rajam and Rengaiah, who are famous venerologists who have worked so much in the field of venerology, and they actually published an elaborate monogram on Donovanosis. And there is another scientist known as Manson who described the clinical features thoroughly, and he called it pudendal ulcerative granuloma. And Donovan detailed the presence of intracellular inclusions in macrophages after a morphological study with special stains of material extracted from lesions of his patient. But however, he believed that it was caused by a protozoan in just like the leishmaniasis organism. And this concept persisted for 3 decades because it was there was inability to culture the material in different types of culture media. And after him, this intracellular inclusions were later termed Donovan bodies. Donovan bodies in granuloma inguinale were then considered to be protozoa analogous to the Leishman bodies. And so initially the treatment proposed for this condition was antimonials. In 1931, Monbrun and Goodpasture attempted to inoculate the material rich in Donovan bodies, but they were not successful. They were, however, established that the microorganism was not a protozoan. They described a gram-negative bacillus that grew in chorioallantoid membrane filtrate of chicken embryos, and they saw this organism in both capsulated and non-capsulated forms. So now coming to the organism, this organism is now known as Klebsiella granulomatis. It is a gram-negative facultative aerobic cocobacillus. It is generally encapsulated and it is intracytoplasmic and non-motile. And its measurement is in rounded coccus form. It is almost 0.02 to 0.2 microns. In the bacillary form, it measures 1 to 2.5 micron. And these lesions are, these microorganisms are found inside macrophages in the form of small oval bodies called Donovan bodies. And an important feature of this organism, it is stained very easily by almost all the stains that we use for tissue staining. That is Giemsa, Leishman, Wright stain. And immature non-capsulated forms. So the immature forms are non-capsulated and they appear as closed safety pins. It's often asked in multiple choice question, closed safety pins with certain stains. Why? Because of the safety pins on both sides, that rounded things are bipolar chromatin densities. So that is a reason for the safety pin appearance. And division occurs by, the cell division occurs by invagination of the cell wall and cytoplastic membrane. And the transmission electron microscopy of the cultured bacteria demonstrated a typical gram-negative cell wall. It is composed of an outer membrane, middle opaque layer, and inner plasma membrane. And filamentous processes recognized as pili and fimbria are present on the surface of most of the organisms. So it is important to know the structure of the organisms. It can come as some short notes or some discussions, so it is important. And epidemiology, it is initially found commonly in the blacks and those with poor hygiene. It is endemic in tropical and subtropical countries such as New Guinea, South Africa, India, Indonesia, Australia, Caribbean, Argentina, French Guyana, and Brazil. However, the distribution is more likely due to the socioeconomic conditions and living conditions rather than the racial or geographic factors. And for long, there was an argument whether this disease was actually an STD or not. So there have been certain points suggesting why it is an STD. So the incidence of this disease is highly seen in the age group of greater sexual activity. And most of the lesions are found in the internal genitalia, such as the uterine cervix, without other manifestation. Presence of anal lesions were associated with the presence of practice of anal sex. And external genital or near genital lesions are the characteristic point of presentation in most cases of Donovanosis. And often patients can have concomitant STIs, and sex workers usually have higher incidence of this disease. So these are the points in favor of STD. And why it is thought to be not an STD, because there was occurrence of this disease in children and adults without sexual activity. And some say that in sex workers compared to other STDs, this is relatively rarer. But I think that generally Donovanosis is rarer compared to the other STDs. Maybe that's a reason. And incubation period is often unclear. It's a variant incubation period for this disease. And low rates of infection among sexual partners in some geographic areas. And also in homosexuals, there have been reports of non-genital and extragenital lesions. And so there was a isolation of this organism from feces of a patient with Donovanosis, which was morphologically similar to Calamity grandomatis. So it was thought that probably it is not an STD. And there is a wonderful CME article which you can refer to, which gives details about this. It was published in 2020 in the Brazilian Dermatology Journal. It is a comprehensive article. It gives a lot of information about Donovanosis. And the clinical features, the incubation period, as I already mentioned, it is controversial and not well established in literature. And studies report variable periods from as variant as 2 weeks to 50 days. But generally, the average period of incubation period thought to be is 21 days, 3 to 4 weeks. And clinically, genitalia is the main affected area. 90% of the cases affects the genitalia and inguinal region in 10% of the cases. Extragenital involvement is seen in 6%. It's quite a good number. Region mainly affected in men are the coronal group, belanopreputial area and the anus. And women, it is mainly the labia minora, vaginal foreskin. And occasionally the cervix and the upper genital tract is involved. And an important feature about this disease is, since it's a proliferative growth, it often simulates carcinomas. And evolution of the disease, it often starts with a papillar lesion or subcutaneous nodule, which evolves to ulceration with papillar surface or subcutaneous nodule at the inoculation site. Ulcer is a erythematous, shiny, friable, and slow growing surface. It's very important because these features will help us distinguishing from other STDs, other genital ulcer disease. So we should know it is a shiny, friable, and erythematous glistening surface, and auto-inoculation, which produces new lesions by contacting the adjacent skin. That is, kissing lesions is a common feature. Generally, the lesions are not painful and there is no inguinal adenopathy. However, you can have a swelling in the inguinal region simulating a bubo. So granuloma inguinal or Donovanosis, you see pseudobubo. And pseudobubo, what are they? They are subcutaneous granuloma which occur in the area of the inguinal lymph node. So they are not actual lymph node involvement, but they are subcutaneous granuloma. And you know where how bubo is in LGV. And you have various morphological types of Donovanosis. You have an ulcerogranulomatous type, that is a classical type. We always describe the ulcer of Donovanosis as having a beefy red granulation tissue. They are non-tender and readily bleeding to touch. And often these lesions are quite exuberant. They grow to large sizes. And you have vegetative forms. They are lesions without secretion that usually present with small dimensions and well-defined ulcers. And you have hypertrophic or verrucous ulcer, which has an irregular edge and sometimes dry. You have necrotic type, which is causes tissue destruction. You have the dry sclerotic or cicatricial lesion with fibrous and scar tissue. And characteristic feature of this ulcer is it has a serpiginous outline. So this is a nodular ulcerative form. You have a classical ulcer which bleeds readily on touch with a beefy red granulation tissue. This is showing the vegetative lesions. So this is a serpiginous outline. This is quite characteristic of Donovanosis. So they go to large sizes, having a serpiginous outline and ulcer which readily bleeds on touch and beefy red granulation tissue. These are the key points you could remember about the ulcer of Donovanosis. And you often have extragenital lesions, maybe the consequence of sexual practices, or it can occur through direct inoculation in areas with continuity, particularly through contaminated fingers. which is possibly the most frequent form. The most common site of extragenital Donovanosis is oral cavity. In the oral cavity, you have lips, gums, jaw, palate, larynx, pharynx. Also, other sites like neck, nose, ophthalmic region, armpits, chest, abdomen, scalp. There have been a lot of case reports of Donovanosis lesions at these sites. And system involvement, it is often occurs in immunocompromised patients. There can be involvement of the lungs, bones, and joints, intestines, spleen, liver, uterus, and presence usually as fever, anemia, night sweats, weight loss, and severe toxemia. The problem with this is it is often the diagnosis is rarely suspected. When patient comes with fever, anemia, a lot of systemic symptoms and other organ involvement, often the diagnosis is missed, and thus it can lead to a risky outcome. And in those cases with fatal evolution, the diagnosis was actually made only at necropsy. And pregnancy is also an important risk factor. It is associated with disseminated Donovanosis. And what are the complications? You know about estheomine, pseudoelephantiasis manifestation almost occurs in long-lasting ulcerated forms. The lesions usually heal with intense fibrosis, and due to the fibrosis they can cause destruction of the lymphatic pathways, slightly different from the type that you see in LGV. Here the pathogenesis of the pseudoelephantiasis or estheomine manifestation is actually thought to be a mechanical pressure by the scarred ulcer on the lymphatic tissues and then further causing lymphatic damage. Direct infiltration of the lymphatics by this organism is not very common as in LGV. LGV is mainly a lymphatic disease. Here it is mainly the skin and the subcutaneous tissue, and the pressure on that, because you have these inguinal lesions, you have large ulcers and they can cause scarring, and thus you can have lymphatic involvement and pseudoelephantiasis manifestation. And these forms are mainly observed in the female genitalia, much rarer in the male genitalia. And deforming and unsightly mutilations and scarring, that is a very important sequelae of Donovanosis. And they can get converted or transformed to squamous cell carcinoma. So particularly in cases with long standing and long evolution period, you should think about a squamous cell carcinoma. And if not diagnosed and treated in timely manner, nearby metastasis to neighboring and distant organs, and as I said, disseminated Donovanosis is often a life-threatening problem. And other complications that can affect these patients are scar adhesion of the scrotum to the penis, destruction of the penis body, stenosis of the urethral, vaginal and anal orifices. So you can have stenosis and scar adhesions. And as I said, in immunocompromised patient, hematogenic dissemination and organ involvement and osteolytic lesions in the bone. So what is the relation between HIV and Donovanosis? And the presence of genital ulcerations increases the risk of HIV transmission up to 4.7 times after unprotected sexual exposure. Probably because these are very easily bleeding ulcers, there is a high risk factor for acquisition of HIV, and which increases with the longer duration of injuries. And this Donovanosis is endemic in countries like Durban, part of South Africa. So it has led to high transmission of HIV in these areas. So very important that any patient who comes with Donovanosis, for that matter, all STDs, is very important to do HIV test, guidance and counseling. And co-infection with HIV usually causes persistent ulcers. So in a patient with HIV positive presenting with Donovanosis, the feature will be the ulcers will be persistent for longer periods and treatment will be for long duration compared to HIV negative. And as I said, the risk for dissemination and organ systemic involvement will be more. So what are the differential diagnoses? It's very important. So the most common lesions that can cause confusion are primary syphilis, ulcerated genital warts and chancroids. So usual DDs are our other genital ulcer diseases, and the late manifestation of LGV due to lymphatic obstruction closely mimics the pseudoelephantiasis of Donovanosis. And there is a variant of chancroid which has strong resemblance to Donovanosis, which is called pseudogranuloma inguinale. So the differential diagnosis considered are, when you have a genital ulcer or bubo, you need to consider syphilis, genital warts with ulceration, chancroid. Chancroid also has rare vegetative variants, phagdinic variants. So those can be confused for Donovanosis. And in patients with lymphatic obstruction, the most important differential diagnosis to consider is LGV. And you have certain necrotic forms of Donovanosis can be often confused with squamous cell carcinoma, amoebiasis, and tuberculosis. And disseminated Donovanosis, especially involving liver, spleen, bone involvement, can be mistaken for tuberculosis. So important differential diagnosis is tuberculosis, and tuberculosis has to be ruled out because that is the most common uh, uh, diagnosis in our part of the country. And histopathologically, Donovanosis can mimic rhinoscleroma. Leishmaniasis is overlapping differential, and histoplasmosis. So how do you approach a case of Donovanosis? In the history taking, it is very important to know about the evolution of the genital lesion. You should ask for any source or growth in the genital area, how long, whether it is recurrent, painful or not, history of previous attack, any medications that patients have taken, because some of the antibiotics can cause spontaneous healing, not for Donovanosis, some other genital ulcer diseases. And swelling in the inguinal area, very important, painful or painless. And what is the nature of the bubo, whether it is uniloculated, multiloculated, all those things we have to note. And whether there is any systemic symptoms like fever, joint pain, redness of eyes, jaundice. You should take history of the treatment, how were the symptoms after taking the medication, how much dose, how long did the patient take these medication, history of venereal diseases in the past, blood transfusion, other illnesses, and sexual contact history, very important, because it is basically from the incubation period that we arrive at a diagnosis. So that is the importance of taking a sexual history, short incubation period, long incubation period, and patient with very highly promiscuous individual, they can have concomitant STDs. So you need to know whether it's a protected intercourse or not. You need, and the important also of the contact person, that is also very important. And also the menstrual history is very important, and gynecological and obstetric history regarding use of contraception, whether the patient has dyspareunia, pregnancy, whether about the pregnancy outcomes and history of pregnancy. These are all very important. And in the examination, generally, as for all patients, we do a general examination, but lymphadenopathy and generalized lymphadenopathy also could be there if a patient is an HIV positive individual. So never miss examination of the lymph nodes. It's very important. I think these days we have a tendency to, in any dermatology case, especially in genital ulcer disease and all, we just look at the inguinal lymph nodes. We don't look at all the lymph node areas. It's very important to see all the lymph node areas. Then inspection, you see the inguinal area, see for swelling, if there's any overlying skin has any ulcers, sinuses, and look for the pubic area for other infestations like scabies, pediculosis, furuncles, because these are all can be a differential, furuncles and all can be a differential for GUD, so genital ulcer disease. So it's important. Then when you examine for the males, you need to see the scrotum, spermatic cord for the size, consistency, sensation. To do a penile examination, look for rashes, ulcer, retracted foreskin, then examine the coronal sulcus, frenulum, urethral meatus. If the patient has urethral discharge, look for urethral discharge. Otherwise, you can milk and see, and examine the underclothes for any stains. An examination of the perianal area. I think that is also one point that we might miss. So examination of perianal area is very important, and ideal situation, we should do a proctoscopic examination to look for the anal lesions, whether the patient has any anal contact, whether he is a person having a male sex with a male person, that and all is very important. And in females, lithotomy is the best position for examination. Examination should be fast, and you should do it in a very quick way, and reassure the patient, not make the patient very conscious so that they become uncooperative. And inguinal and pubic area, look for vulval lesions, discharge, look at the Bartholin gland. Perianal area, again, very important. And actually take a consent and look a perspeculum examination, look at the cervix, take a smear. Urethral examination should be done last. You should do a bimanual examination and rectal examination also in females. So how do we diagnose? Direct microscopy is the fastest, most economical and reliable diagnostic method. The material should preferably be collected from areas of active granulation that do not show signs of secondary infection. And how do we take? From the edge of the smear should be collected from part of the fragment taken for biopsy, and crush the specimen against a glass slide and stain with Giemsa, Leishman or Wright stain. This is what we see. You can see the Donovan bodies in the macrophages in a staining. And biopsy should be performed only, preferably on active lesion. It usually shows acanthosis with pseudoepitheliomatous hypoplasia. And the dermis shows intense inflammatory infiltrate of lymphocytes, plasma cells, histiocytes, and even sometimes few eosinophils. Presence of neutrophilic abscesses in the epidermis is a key feature. And you have bulky histiocytes which show vacuolar and cystic appearance because of the inclusion bodies inside the histiocytes. So the salient features a massive cellular infiltrate, predominance of plasma cells, paucity of lymphocytes, diffuse sprinkling of polymorphonuclear leukocytes, pronounced epithelial proliferation, and large mononuclear cells. And culture of the etiological agent in yolk sac of chick embryo is extremely difficult and not routinely available. Monolayer cell culture has been described now, and use of PCR, that is much practical way to detect granulomatous the organism, but routinely we don't do it. A histopath or a tissue smear often gives us a diagnosis. And the treatment, it is important to know that it has no tendency to spontaneously resolve. This is a condition which does not resolve spontaneously, and optimum duration of treatment should be decided on a case-to-case basis. You can't say a standard duration. If the lesions are small, sometimes it will cure with short courses of treatment, and always know that relapse is quite frequent. And counsel the patient about maintaining the local hygiene of the lesional areas. Intravenous emetic tartar was the earlier treatment described in 1913, but however, with the advent of antibiotics, these became the medication of choice. The first antibiotic effective was streptomycin. Other antibiotics that respond are chloramphenicol, erythromycin, vancomycin, quinolones, and tetracyclines. And the recommended first-line therapy is azithromycin, 2 tablets of 500 mg a week for 3 weeks or until complete healing. That is what I said, there's no standard this thing like 3 weeks or 2 weeks, but you have to wait and closely follow the patient till the lesions are healed. And the important next option is doxycycline, which is what we often give, 100 milligram BD for minimum period of 21 days or until complete healing. Ciprofloxacin is a good option, 750 mg BD for 21 days or until complete healing. Another option is sulfamethoxazole trimethoprim. If there is no response in the aspect of the lesions, the first few days of treatment, some authorities recommend that you can add IV aminoglycoside, which is such as gentamicin, 1 mg per kg per day, 3 times a day for at least 21 days. And if an antibiotic is effective, the lesions become paler and shrink by peripheral epithelialization. They also say that if you take a smear after 7 days, Donovan bodies disappear. And if the lesions are changed after 2 weeks of a particular antibiotic, you should think about an alternative antibiotic regimen. And in pregnancy, it is erythromycin stearate 500 mg BD 4 times a day for 21 days. In refractory lesions of patients who are immunosuppressed or HIV positive, the same therapeutic regimens and use of parenteral therapy with IV gentamicin, IV chloramphenicol if it is a very severe type. And azithromycin should be considered as prophylactic treatment in neonates of mothers with genital lesions of Donovanosis in a dose of 20 mg per kg for 3 days that has been recommended. And WHO recommended regimen is azithromycin 1 gram orally on the first day, then 500 mg once daily. And CDC recommends 100 mg doxycycline BD for at least 3 weeks. And surgery has been needed for or recommended for people with persistent complications of ulceration and scarring after adequate antibiotic treatment has been administered. If lesions persist or there is problem with scarring or mutilation, you can think about surgical corrections. And partner treatment. All persons who have had sexual contact with a granuloma inguinal patient within 60 days of onset of before the onset of patient's symptoms should be examined and offered therapy. So what are the take-home points? Just a review of salient features of Donovanosis. It's a chronic, progressive and indolent bacterial disease caused by Klebsiella granulomatous. It is a gram-negative cocobacilli. Characteristic feature is granulomatous ulceration of the genitalia and neighboring area. You have 4 variants: ulcerogranulomatous, hypertrophic, verrucous, necrotic and dry, sclerotic or cicatricial lesion. And you know about pseudobubo because it is not true lymphadenopathy. And the gold standard of diagnosis of Donovanosis is by demonstration of the intracellular Donovan bodies from the material of the lesion, so from the lesional smear. Thank you all. Thank you for the patient listening.
Thank you, Dr. Vinitha. It is very crisp and to the point. Thank you very much. And the postgraduates would love the presentation.
Thank you, sir.
Thank you, Dr. Vinitha. We will move on to the second part of the today's program. In this, we are going to have a very good speaker from this very same institute, Amrita Institute of Medical Sciences, is Dr. Gopikrishnan Anjaneyan. He is talking about the genital. Over to you, Dr. Gopikrishnan.
Thank you, sir. Thank you for the kind words and the introduction, sir. So as sir rightly said, herpes genitalis. Earlier, we had, out of all the sexually transmitted infections, earlier we had a rise of bacterial infections. Then with the advent of antibiotics, you all know the viral infections started increasing in number globally. And slowly, now we are seeing, I'm sure most of you must be seeing more of syphilis cases now as well. So, but the viral STIs are still on the rise, very much on the rise. So with that, I'll start my presentation. So herpes genitalis. So that's the topic now we are going to learn after a wonderful presentation on Donovanosis. So these are the basic things what I'll be discussing. The epidemiology, some statistics around the world. What are the various types of infections? Or various clinical types. What are the pathogenesis? A small slide on pathogenesis, not in detail, of course. Transmission, a bit about clinical features, how it is diagnosed, and the treatment. And we'll also discuss about certain special situations like pregnancy and HIV, which is very important in HSV infection. So as you all know, herpes genitalis is among the most common sexually transmitted infections globally. It is caused by HSV2, what we have learned in UG PG days as well, that HSV is mainly for genitalia, whereas HSV2 one mainly causes oral, but that is not the case, as all of you know. Herpes genitalis is caused by HSV2 as well as HSV1 due to various sexual practices, as well as both organisms are DNA viruses. and they have a marked genetic homology as well, HSV1 and 2, and that's the reason that because of various antigenic cross reactions, even the effect of the virus on the human body is also may also vary. For example, if a patient has already got an infection of HSV2 1 in the past, it will be slightly different the second time the patient gets HSV2. So why knowing about HSV is important? One, of course, in our clinical diagnosis and all, but also you have to know that it is one of the major global public health problem as well. And there is, as we said, though there are bacterial STIs which are coming back a number in a big way, still there is an upsurge of genital HSV infection, which is evident from various worldwide seroprevalence studies. And second point, of course, is the clinical spectrum of genital HSV can be varied depending on what kind of an infection it is, where it has affected, various manifestations, the host itself, that is the agent. As you all know, there is an epidemiological triad of host, agent as and the environment. So agent, of course, remains the same, but still HSV1 and 2 may have some mild varying presentation, milder in HSV1 and a bit more severe. But then when it is primary infection, when it's the first time the patient gets it, it might be more severe and more widespread. Then the host as well. If the patient is immunosuppressed, then or a pregnant lady may get a more severe infection compared to a general population. So the clinical spectrum of HSV is wide and varied depending on the infection, the type, serotype, as well as the host immunity, age, even age as well. So HSV, what it basically does is it establishes a latent state followed by a viral reactivation. So many patients may get a reactivation after the primary episode. That is another reason why it has become a major public health problem. Then one of the most important thing is the vertical transmission. That is the transmission from mother to child. And that may lead to, though it is rare, but still it may lead to significant morbidity and even mortality if not treated or if not diagnosed and treated at the earliest. And of course, as Sir also mentioned, there has been a link which has been established between herpes simplex genital ulcerative disease with HIV transmission. So HSV basically can increase HIV transmission and vice versa, but HSV inducing an HIV transmission is much higher. So a bit about epidemiology. So genital HSV is frequently under-recognized because the infection is often subclinical. As you all know, many of the times the patients who come to you are males, females. Many times they don't even present because the symptoms may be mild, especially recurrent, unless it is a primary infection. And you know, both HSV1 and 2 can cause genital herpes, as I already said. But most cases of recurrent genital herpes, patients, when they keep coming back to you with the same episode, with the same symptoms, most of them are normally caused by HSV2 than HSV1. And you all must be knowing that it is the only natural host. Humans are the only natural host, and transmission is only by direct contact between mucocutaneous surfaces. The seroprevalence, that is the seroprevalence of HSV1 and 2, increases with age, with the number of sexual partners, and of course is a bit more common in women than in men, females than in males, though we see more cases of males in our general practice, but females, actually the seroprevalence is much more according to various studies. And according to this study, actually HSV1 seroprevalence globally, there are 3.7 billion people under the age of 50 globally who have a seroprevalence or who are HSV1 seropositive, and HSV2 infection is close to 500 million. Yeah. So coming to India, in India, the seroprevalence studies are few, and the range the studies which have been conducted in various STI clinics, of course, the number would be very high. They have ranged between 43 to 83% in various studies. And in the population-based studies, it has ranged, still it is on the higher side, 8 to 14%. One of the studies, a meta-analysis, actually gave a very high seroprevalence, but that was done only for HSV1. So that was 67% seroprevalence. This was basically meta-analysis of various studies which had been done from India, but this is only for HSV1. Another study, a recent study published in 2023, showed that the HSV2 that they studied mainly in the Middle East and North Africa, that is MENA, Middle East and North Africa. So basically, the HSV2 seroprevalence in the adult general population of Middle East and North Africa averaged around 5%. And it is of course much lower than in Africa. They found that it is 37%, in Asia it was 12%, and USA it was 15%. Another interesting point is, of course, we all know that the bridge population is very important, the high risk population. So they also found that the seroprevalence, though it was lowest among the general population, as we would imagine, 5%, it was highest among the higher risk population, like female sex workers 20% and male sex workers 18%. And compared to men, here also women had a higher pool mean across all populations. So coming directly to the types of infections, what are the types of infections? What are the variants of the clinical infections? The first you should know in herpes infection is a primary infection. So that is the first time a naive individual getting an infection the first time, either with HSV1 or HSV2. So basically, because the patient has never been exposed to HSV1 or 2, hence they don't have any pre-existing antibodies, and that's called as a primary infection. That's the first time patient presents to you. Now, there is a similar but not confusing term called a non-primary first episode. So non-primary first episode means basically patient has been exposed to either HSV1 or 2 in the past, but this time the patient comes with the second infection with the second serotype. So basically, if the patient has already had a HSV1 in the past, so that means the patient already has HSV1 antibodies, and this time patient gets HSV2, or vice versa. Patient had got HSV2, so has pre-formed antibodies. This time patient gets HSV1. So that is called as designated as the non-primary first episode. Then, of course, these patients have a tendency after the primary or the non-primary first episode to have a recurrent infection. We'll come to pathogenesis, why it happens. So basically, recurrent infections are where the HSV serotype is recovered in the lesion is the same as the antibodies. When we check for the seroprevalence studies, like they check for antibodies, it is found that HSV, for example, HSV2 from the lesion as well as from the serum. And all these infections actually can be, most cases, primary is always symptomatic, but you can even have asymptomatic or the subclinical types. And recurrent many times are asymptomatic, but there is always a viral shedding and there is always a chance of transmission. So quick word about pathogenesis. So basically, as we said, HSV enters through skin defects so there should be a portal of entry in the skin, and there should be a tiny erosion, even a micro abrasion is fine for a virus to go in. Then what happens? The next step is the local multiplication in the local lymph node. Then there is an axonal flow, a retrograde axonal flow from the sensory nerves. It reaches the ganglia, and there it stays. It stays till the primary index patient, has some stress induced or an immunodeficiency, any other illnesses, where at that time when we have stress, our body becomes a little weak, and that's the time where the viral replication starts again, and that's the time we have a decreased immunity, and the migration to skin and mucous membrane happens, and hence we get a recurrence of the disease. That is in short about what happens in recurrent infections. So coming to transmission, already we said a natural host is human, and transmission is only via direct contact. So what the other points to be known is transmission only when there is a small erosion in the genital area, it can be transmitted to a partner. And a prospective study of which was published way back in 2006 showed that in a prospective study of 200 patients with newly acquired HSV genital infection, the mean duration of the sexual relationship of the patient was 3.5 months, and the median number of sexual acts before the transmission was 40. So it can start early, within 3 months of the sexual relationship itself, and the median number of acts was before the transmission was 40. And in these cases, condom use was infamous. So, as we said, only if there is a contact between the mucocutaneous surfaces, there is a chance of spread. So, barrier protection, the use of condoms and all is very helpful. And this study, it was found that it was infrequent. And another important finding which I wanted to highlight, and hence I have put here, is basically the median time to infection was greater in participants whose partners informed them that they had genital herpes than in those whose partner did not. So that is 270 to 60 days. So basically, this doesn't show anything about the disease or the serotype assay. This just says that if the partner informs his or her partner that they have had genital herpes in the past, uh, the other person would be a bit more careful, a bit more vigilant, and hence they would take a timely treatment and timely management. So that's very important point what we get from this study as well. So basically, information of the sexual partner about the prior infection in the index case is also very important. So coming to clinical features, so the primary infection, as you said, so the average incubation period is very important from the time the virus affects the genitalia to the start of the symptoms. Normally, on an average, it is 4 days, but it can range from 2 to 12 days. We learn that it is 7 days and all, but the range is 2 to 12 days. So the initial presentation is very important. It can be very severe in primary infection, very severe in primary infection, which can present as multiple painful genital ulcers. It can present with dysuria, fever, and local lymphadenopathy because of the effect of the lymph nodes as well. And in some cases, of course, it is mild, subclinical, or totally asymptomatic. So the vesicular eruption, the grouped vesicular eruption, is the classical presentation what we see in all genital herpes. But the problem is most of the times the patient may see it, but by the time they come to us, the vesicles must have gone and they may have transformed into erosions. So grouped vesicles are the classical lesions of genital herpes, but it is difficult to see and they may progress to vesiculopustules at times. Pustular eruption may happen normally or even with a secondary infection. And most of the times when we see the patient, it's already become eroded or ulcerated. So vesicles have been described by some authors as presenting with an umbilicated appearance as well. The erosion ulcerations, that is something which you should know, presents with multiple polycyclic borders, nice polycyclic borders, and they may be irregular. And symptoms, this has been noticed in our personal experience as well. Symptoms tend to be much more severe in primary infection in females than in males. So these are some of the photographs you can see. Uh, the first photo is from one of my patients. Actually, you can see this is one of the very rare cases where we could actually see vesicles. We see often, but it is rare. So others have been taken from the net. You can see the grouped vesicular eruption, very fine vesicles, and these vesicles may become pustular at times. May become pustular at times, but the morphology, the grouped lesions are very classical. So if you're not lucky to find those, if the patients come after few days, then probably you would see something like this, where you can see a mild discharge or seropurulent discharge, like you can see in these first two cases on the left. And you may many times see just erosion, like the image in the middle. You may just see an erosion there. But they will also have certain borders, like you can see here in the female genital system. You can see the erosions will have borders. You can see the right bottom image where the borders are also slightly irregular but polycyclic. And this polycyclic appearance, grouped appearance, multiple lesions, superficial ulcerations are some of the classic examination points which can help you in reaching a diagnosis, reaching a clinical diagnosis. Some more images, you can see there is a mild crusting, but again, what I told you, basically the erosions can also give us a very good idea about what kind, if you're dealing with herpes genitalis infection. So in cases where there is a severe primary HSV infection, the systemic symptoms may be may be very severe. They can present with constitutional symptoms like fever, headache, malaise, and myalgias. And primary genital herpes is even associated with viremia too at times. Now, it is very important if a patient presents with all these symptoms and even complains of difficulty in micturition. So that is very important because there are two things which can happen. One is a simple dysuria, that is just a burning sensation, a reluctance to avoid urine because when urine passes on to the what do you say, those erosions and all, you will of course have burning sensations. So that is common dysuria. But if there is a urinary retention, and the reason of urinary retention is not because of the burning sensation, then that is very important. So as clinicians, we should always differentiate between these two things. So if there is an acute urinary retention, then that could be due to the loss of sacral sensations, which can occur due to lumbosacral radiculomyelitis, which is a very rare complication of severe primary HSV, and that should be immediately, a patient should be catheterized and immediately started on IV acyclovir. So next, as we discussed, is a non-primary infection. So patient already had one serotype, and this is the second serotype what patient developed. So the lesions normally are milder, fewer lesions, and less systemic symptoms compared to the primary. And here, because the reason basically is the antibodies from the previous HSV type will offer some protection, not complete protection, but only some protection. Now, there have also been studies which have shown that a prior HSV-1 infection may increase the likelihood of asymptomatic infection threefold. So basically, the first time patient had an HSV-1 infection, second time patient actually developed the genital HSV-2 infection. Now, in these cases, patient will have lesions and will have a asymptomatic shedding as well. But basically the symptoms, the asymptomatic the patient will be asymptomatic 3 times than a normal patient who probably did not have a prior HSV infection. Those patients would have more symptoms than compared to a person who had an HSV. I hope I'm clear. I'll just say again, basically a patient who patient A had an HSV-1 infection, patient B had an HSV, did not have an HSV-1 infection, then it is much more likely that the patient A who had HSV-1 infection will have an asymptomatic infection. That is, will not develop vesicles, or the vesicles will remain only for few days. So then next is the third type, is the recurrent infection. This is very important from a public health perspective as well, because the clinical recurrences of a genital HSV is again common, but it is normally less severe. So the problem to the patient is less, but what we are worried about is the viral shedding. So these patients basically present with, they will say that the first, when they come to you the second time, the first time the lesions must have persisted for like 7 days or even 3 weeks. So the second time the lesions may persist only for a week or even less than a week. But the duration of viral shedding is at least 2 to 5 days. So that is very important. So the chances of spreading to the partner is always there for at least 5 days. So patients should be advised to use barrier contraceptives. Then the systemic symptoms are infrequent, of course, here, and 25% are completely asymptomatic. So they don't have any, 1/4 of the patients, they don't have any symptoms at all. They won't even know that they had the recurrent episode. Now, 50% of the patients, this is another important thing, that many of the times patients would tell you that, sir, normally I would understand when the symptoms start, because they don't actually get the lesions, but what they will get is a prodromal symptom, that is a mild tingling or a shooting pain, because of course the nerve is involved, and that may be radiated to the buttocks, legs, as well as hips. And the factors that contribute to decreased recurrence, basically decreased recurrences, include infection in HSV-1 compared to HSV-2. So basically, when you have an HSV-2, you have more chances of recurrence compared to HSV-1, and the severity of the and the duration and severity of the primary infection. So, for example, if a patient had probably the infection which was very severe and which stayed on for 3 to 4 weeks, those patients will have more chances of recurrence compared to another patient who had a primary infection, but it stayed on only for 1 week. So that's an important thing, which again helps you in even counseling the patient. So if a patient comes to you for a 3 weeks history of a herpes genitalis, which persists for 3 weeks, it's better always to counsel them that you have more chances of recurrence. So then extragenital complications is very rare, but we should be familiar with that. HSV meningitis is something which is seen, and when you do a CSF sampling, HSV has been isolated from 0.5 to 3% of CSF sample, and the CSF analysis will show that the white blood cell count has increased with a predominance of lymphocytes with a normal CSF glucose. Another important thing for your MCQs or quiz and all, what you can know is there is something called as a Mollaret's meningitis. It's an aseptic meningitis, but there is a hypothesis that Mollaret's meningitis is caused more due to HSV2 infection, and this is basically a recurrent episodes of meningitis. Next thing important, what we already discussed in the past, basically is an acute urinary retention that may happen in patients who have a sacral radiculitis. So that is important. It can happen in patients who have severe primary HSV infection, and this requires catheterization and immediate treatment with IV acyclovir. Then proctitis, other end organ damage like hepatitis, pneumonitis can occur, especially in cases of disseminated HSV infection as well. So recurrences, what you have to know about recurrences, and it's always better to counsel those patients who come to you with a genital herpes. It's better to be safe than sorry, and tell them that it is possible that you may have a recurrence of this disease. So you have to take a treatment from a dermatologist, a venerologist. You should always explain to the patient. So the frequency, as we already discussed, depends on the severity and the duration of the initial episode. I think this we already discussed. Yeah, another important point is it's more common in HSV2 and 1. I already said. Another important thing is more common in immunosuppressed patients or people who are on medications, or even patients who are HIV positive. Then another important point which I wanted to highlight is about the viral shedding. We already discussed the viral shedding can happen in patients who are symptomatic as well as in asymptomatic patients. It can happen in both men and women, even in the absence of genital lesions. So again, shedding is again influenced by three factors. One is the infecting serotype. So HSV2 is known to have more viral shedding and prolonged viral shedding. So it is more frequent and more prolonged viral shedding compared to a patient who is infected with HSV1. The infection, whether it is primary or non-primary. So basically, there is a controversy, but most cases the viral shedding is a bit more in primary than compared to non-primary. But there are some studies which have shown that even non-primary is almost similar to the primary infection, the viral shedding. And another important thing is basically the time since the first clinical episode. So basically, if the duration between the first clinical episode and the recurrent episode is much longer, then the viral shedding will be much lower. So it is indirectly proportional. So if a patient gets an infection, recurrent infection within few weeks or few months, then the chances of viral shedding would be much higher. So these are the three things where viral shedding depends on. Then the role of sexual partners, of course, the risk is much higher with a male than with a female. So though the females have higher seroprevalence and all, but the risk is higher when your male partner has HSV positive of you getting it. Then in susceptible women who lacked HSV1, this is basically as per a study, who lacked HSV1 and HSV2 antibodies at the entry, the rate of acquiring genital herpes infection is much higher than in a woman who already had a pre-existing HSV antibody. So this was 32 versus 3%. I think the 3 we missed there. So it is much higher in a person who never had an infection before, and compared to a person who already had an HSV1 antibody before. And in 30% of the patients, the transmission of genital herpes was linked to a sexual contact during periods of asymptomatic viral shedding. So this study, when it was done, and the patients who presented, when they were asked and the partner was asked, it was understood that at the time of sexual activity, there were no lesions, but it was just because of the asymptomatic viral shedding why it happens. So the role of sexual partners is very important in herpes genital, in fact, for all STIs. So differential diagnosis, I think I'll quickly go because the presentation is taking. So differential diagnosis, as you know, the infective differential infections are the commonest Syphilis and chancroid are the commonest according to the morphology of the skin lesions. As you can see, this is just herpes simplex infection itself from the previous slides, but still it may mimic a chancroid or a syphilis. Then non-venereal diseases also you should know. Drug reactions like Pick's drug eruptions, aphthous ulcers in Behçet syndrome, basically Lipschutz ulcer. Lipschutz ulcer is basically infections which can happen in females, young females commonly, but you can see in elder females as well after any infection. Then you can even have irritant dermatitis. Many patients present with irritant dermatitis as well, which can mimic a herpes infection. So quickly coming to the diagnosis is majorly clinical, but you have to confirm it with a lab testing ideally, but which is it is something which is not possible in India all the time. But you should know what are the diagnostic measures which are diagnostic methods which are available. Viral cultures are the best, but the sensitivity is low. Then we have a polymerase chain reaction, which is much more commonly used, which has very high sensitivity and specificity. Then a DFA, direct fluorescence antibody, and type-specific serological tests. So viral cultures, a point on that, sensitivity is low, but it is very specific. And the specimens in the viral culture media have to be rapidly transported to the laboratory. Usually we can get results within 5 days if it is positive. Yeah, another important slide about when to consider serological testing. So we all know the serological testing IgM and IgG is available against HSV1, but when should we do it? So basically, according to the guidelines or the studies and all which have been done, HSV, many times PCR and cultures are not available. That is the reason we do it. But ideally, in an ideal scenario, it should be done only when you have a negative culture or a PCR, but still you doubt that the patient has genital ulcer, which is suggestive of herpes, or a patient who presents with an atypical presentation. Now, IgM typing normally is not specific IgM, so it cannot differentiate between an HSV1 and an HSV2, and hence it is normally not indicated. That is one. But if an IgG HSV2 is positive, then it typically indicates an anogenital infection, whereas IgG HSV1 is positive, then it is more likely, it can either be an anogenital or a orolabial infection. But one thing to know and for sure is basically if you get a person who gets an IgG HSV positive, that doesn't mean that is not confirmatory for the genital ulcer, because as you all know, genital ulcers you can have multiple causes. So just a seroprevalence, that is seropositivity of IgG HSV in a patient, is not a diagnosis of HSV in that patient, because low sensitivity is there. So because serological tests have low sensitivity, and so false negative results are also high. And Zhang smear, Zhang smear basically can be done with Gimsa. This is how it looks like. Basically, you do take an active vesicle, deroof it, and do stain it with Gimsa, and you will see epithelial multinucleated giants. So routine screening, serology is not done. Then management of herpes genitalis, I'll quickly move. Basically, general measures, antiviral therapy, partner treatment is very, very important, a regular follow-up, and counsel in detail about complications, and especially if they're planning to pregnant, or tell them that in pregnancy, especially a female who comes to you unmarried, but you should inform them that when they get married, there is always a chance of you have to be extra careful during pregnancy. So treatment, according to the CDC guidelines, we have to initiate treatment as early as possible, and it should ideally be within 3 days. But still, if a patient keeps getting new lesions, then you can even give it beyond 3 days, beyond 72 hours, it can be given. So acyclovir, the dosage is 400 milligram TID for 7 to 10 days. You can even choose to use valacyclovir 1 gram twice a day for 7 to 10 days, which is very commonly given in India. Famciclovir is also there, 250 milligram 3 times a day. So when you have complicated infections like we discussed, you have to give IV acyclovir 5 to 10 milligram per kg every 8 hours till there is a clinical improvement. Now, treatment of recurrent infection is an important point, because why we have to treat recurrent infection is, one, to of course reduce the severity of the symptoms if the patient is really symptomatic. Second is to decrease the risk of recurrences. And third and most important point is in discordant couples where husband has it and wife doesn't have it, or wife has it, husband doesn't have it. it is very important to reduce the shedding and the risk of transmission to the uninfected sexual partner. So there are two ways where you can give. One is an episodic therapy, episodic prophylaxis, or a chronic suppressive therapy, where you can give a daily antiviral therapy. So I'll come to that. What is episodic therapy? In episodic therapy, basically, you give it only during the episodes. Many times, the patient themselves take it, and they don't have to meet a physician or a dermatologist. They don't meet normally. So episodic treatment is given normally when the episodes are much fewer. So if it is less than 6 times, that is the cutoff. But it can vary depending on the symptoms as well. If the patient is getting only 5 episodes per year, still the symptoms are very, very severe, then you can still offer them this prophylactic treatment option. So basically, episodic prophylactic is preferred if it is less than 6. If it is more than 6 episodes per year, you have to give or give an option of suppressive prophylaxis. But of course, you have to tailor make it for each patient individually. So episodic prophylaxis is acyclovir 800 milligram 3 times daily for just 2 days, or 800 milligram twice a day for 5 days. Though the dosage is different, but 2 days if it is 3 times a day, and if it is twice a day, then 5 days. Valacyclovir is another preferred drug, which is 500 milligram twice daily for 3 days, or 1 gram once daily for 5 days. In suppressive prophylaxis, we give a daily dosing, that is 400 milligram twice daily, famciclovir 250 milligram twice daily, and valacyclovir either 500 milligram once daily, or 1000 milligram in case of more severe infection or more recurrent disease. So this you have to understand, there is no timeline when you can stop it. In most studies, they say that studies have been done for 6 years, even for 10 years. So this, a patient and a doctor can decide till when they want to continue the treatment. Books do mention 1 year, 2 years and all, but an annual review is to be done. Acyclovir, valacyclovir are one of the safest drugs which are available. So in suppressive prophylaxis, you can even give it for years, even 5 to 10 years also has been mentioned. So another important thing you should know, I'm not going to go into detail, is a syndromic management. If you see a syndromic management, this is something which you should know as PGs, as dermatologists, and places where you cannot diagnose, you can diagnose by syndromic management. And for cases where you're suspecting herpes, you have to give kit 5, which contains 400 milligram acyclovir, which has to be given 3 times a day for 7 days. So there's just a quick word about it. And one more slide about acyclovir resistance. Acyclovir resistance. Acyclovir resistance. There are various mechanisms of acyclovir resistance because how acyclovir acts is basically by viral thioredoxy kinase to become inhibitor of the viral DNA polymerase, which basically blocks the DNA synthesis and the replication of the replication. And there are various mechanisms by which there can be acyclovir resistance. And I'm not going to detail there, but what is the treatment in acyclovir resistance? This you should know as PGs, that foscarnet is the treatment, and it is given in the dose of 40 milligram per kg body weight, infused intravenously every 8 hours. Then, common question, common PGs also ask us, what is the role of topical therapy? Acyclovir is available as a cream, but there is no role of topical acyclovir in the treatment of genital herpes. There are some studies, again, of course, you will have pros and, some in favor as well. There are some studies which say that there is a marginal improvement if you give, but as such, there is no role of topical antiviral therapy. Topical acyclovir doesn't help. Then one more line about a newer treatment advance. Basically, pritelivir is an inhibitor of HSV2 helicase primase complex, and it is thought it is being studied for use in herpes genitalis, and it acts through a mechanism that is slightly different from the 3 common drugs which are available, which are work again they are nucleoside analogs. But pritelivir is basically an inhibitor of the HSV2 helicase primase complex. Now, in special situations, these are my last few slides. So, HSV in pregnancy, that is very important. The vertical transmission can occur to the newborn when they come in direct contact with the virus shed from the cervix, vagina, vulva, or the perianal area. So, this is the most when there is a normal delivery, vaginal delivery, and the person has an active infection, mother has an active infection, then it can be transmitted to the newborn. So many times the mother's the history that is very important. Of course, no mother would want the child to be born to transmit to their child. But the problem here is many of the times mothers lack. So a child gets an HSV, you go and ask the mother whether they had a history. They would not give a history of a clinical evident genital herpes. So that's the most important thing. The shedding as well as the subclinical form or the asymptomatic form which occurs. So that's the most important. But still, you should ask the history. Maternal history should be asked. So gynecologists make sure that that is asked. Then other risk factors is basically the highest risk of neonatal infection occurs in women with a primary genital HSV infection, which is acquired near the time of the delivery. Here again important is during during the last weeks of pregnancy, if they get it, there is much more chances than they get it early in the first trimester, for example. Actually, if they get it during the first trimester or during the second trimester, the antibodies which are produced may be beneficial to the child as well. But that is not so when they get it later on. And that's where it is more important, where our role comes in. So the risk is much lower even in women who have a non-primary first episode genital infection, and it is substantially reduced in women who have a recurrent. So the highest risk is in patients who have a primary first episode of primary genital infection. So the antibodies I already discussed. Yeah. So the viral shedding can occur without maternal symptoms or lesions. This is what we should know. And the frequency is much higher in HSV2 compared to HSV1. Management in pregnancy does not depend on the type or anything. It remains the same as we do in patients, in the pregnant ladies as well. The in utero transmission, what happens in utero transmission of HSV can occur, and it can lead to miscarriage, congenital anomalies, preterm birth, and intrauterine growth restriction. These are all known to occur when there is an in utero transmission. In utero transmission, not through the vertical transmission. Then the monitoring and preterm birth. When a patient, for example, a woman who never had a history, she do not know that she has a history, but an invasive fetal monitoring is done in that person, then that itself, that probe itself will lead to increase in neonatal infection, because suppose history was not taken before an invasive fetal monitoring device was inserted, and that may lead to an increased risk. So a person who doesn't give a history of an infection, doesn't give the history to the the physician who is doing the fetal monitoring, and the person uses an invasive fetal monitoring device, and that can actually lead to an increase in neonatal infection. So the treatment is the same. Basically, treatment is the same in pregnant women. Primary, non-primary, you have to give oral acyclovir recommended. Intravenous acyclovir recommended only for complicated infections. And another very important thing, so that is for primary infection. You have to give an antiviral therapy at 36 week. That is for suppressing and the spread to the child. So if there is a recurrent infection, then treatment is generally not needed. This is another thing you should understand. If there is a recurrent episode, then treatment is not required normally in pregnancy. But again, it should be started at 36 weeks. It should be started in either way. So suppressive therapy at 36 weeks should be started. All pregnant women with genital HSV lesions during pregnancy are advised to start suppressive therapy at 36 weeks until this is also important, until labor begins. So the dose is acyclovir 400 milligram TID. So this definitely reduces the frequency of recurrences, lowers the need for cesarean delivery, and decreases viral shedding. So another just quick point about HSV and HIV. HIV patients with HIV may have a prolonged or severe episode. That's an important thing. A person HIV positive may have a prolonged or severe episode of genital herpes and are at greater risk of developing drug-resistant HSV compared to immunocompetent hosts. So there are again various hypotheses which have been put forward why HSV increases the transmission in HIV. So the symptomatic HSV genital HSV2 genital ulcers will increase the local inflammation, and that local inflammation along with the mucosal disruption, that is the mucosal ulcers, will facilitate easy entry of HIV into the non-infected partner. Second thing is genital HSV2 selectively increases the local recruited for CD4 positive cells, which is again, as you know, is the target for HIV attachment. And studies have shown that HSV2 has threefold increased risk of HIV acquisition compared to the general population, patients who have HSV2 infection. And treatment, of course, is same, but it has to be given longer. Normally, give for 7 to 10 days. We may have to give it for we may have to give it for at least 2 weeks. So last slide about the prevention. So what are the points we have to take care of? Points. Basically, counseling is very important for effective management of patients with genital HSV. Disclosure of HIV status with sexual partner always helps. Sexual activity should be discouraged if the lesions or prodromal symptoms are present, even if a barrier contraceptive like condoms are used. Condoms and barrier contraceptions are definitely useful in prevention of HSV2 and for that matter, all or any STIs. Then chronic suppressive therapy should be advised in discordant couples. So discordant couples, just to refresh your memory, basically husband is positive, wife is negative. It's better to start suppressive therapy in husband because the wife doesn't have the infection to prevent the wife from getting it. And these patients should always be screened for other STIs and HIV. Didn't go into detail about the other, I just went specific HSV testing, but you have to, of course, test for all other STIs as well. And there is no effective prophylactic or a therapeutic vaccine still. So that's my last slide. Just one study I wanted to highlight. This was published in Lancet. So basically, what they tried to do is they tried to see the point with Crichton was also trying to make HSV infection and HIV. So the last line, can just see the last line, an estimated 420,000 of the 1.4 million sexually acquired HIV infections was attributable. The PAFS population attributable factor. So HSV was almost 1/3 of the cases was thought to be due to HSV infection of the whole HIV infection which have been sexually transmitted. It was thought to be. So that's very, very, very important. So that's it. That's my presentation.
Thank you, Dr. Gopikrishnan. It is an interesting talk, and you have covered almost all the aspects of herpes simplex virus infection. And the salient features that everybody should know is greatly emphasized. Thank you very much. And postgraduates will be benefited, and it is a refreshing for those who are not postgraduates. Okay. Thank you, Gopadi, for attending the webinar and also participating in the MCQ. It is an exercise, and it is not a very big competition, just to have a refreshment. Sorry, a rehearsal as you go to the Viva in the final year. Anyway, some of these questions may be asked by the examiners, and you must be prepared for that. Both the speakers have done a great job, and they have given a very detailed description of both the topics. And I am very grateful to both of you, Dr. Vinitha and Dr. Gopikrishnan. And I think thank you very much for both of you. And we will have some more sessions in the coming time also. Thank you.
Thank you for the opportunity, sir.
Thank you for the opportunity for research Pharma, Doctor. So both and also we cordially thank for both speakers. They've given precise content to the PGs for their benefits. And also our post director, we extend our gratitude to our Dr. Katik sir for conducting such a wonderful program for almost this is our 17th program. So we're successfully doing for the past 1.5 years. So we'll continue, and I'm expecting our PGs to share these details to our colleagues also and make them to participate the program to have a successful forthcoming. Thank you so much.
Thank you, Doctor. Thank you, Mr. Nath.